Welcome to Conversations. I'm Suresh Kochattil. Healthcare, they say, is a very serious business. And more so, when you're speaking to somebody with tons of experience under his belt. Today I have with me Dr Sagi Radhakrishna Rao, a celebrated orthopedic surgeon, a visionary healthcare CEO. As a chief consultant, orthopedics and joint replacement, and CEO of the multi-specialty division at Renova Hospitals. He also holds another title for that, the CEO of Connect Diagnostics. Dr. Rao exemplifies a rare duality as a surgeon deeply rooted in patient care and also orchestrates large-scale healthcare transmission. Balancing precision with perspective, he leads a multidisciplinary team that bridges diagnostics, research, advanced clinical practices. Now, let's start rolling our conversation. Welcome, sir. So, the obvious question would be, whenever we start a conversation, is to ask, where did it all start? That is something it's very, very obvious to ask anybody, that where did you start? Where did you do your early days of your education, and how did you get into the healthcare path?
Well, I did my MBBS from Gandhi Medical College in Hyderabad. Then went to Manipal for my post-graduation. Then came back to Hyderabad, did my DNB with St. Teresa's. Then had a short stint with Apollo before going to UK. Then after a year, less than a year actually, realized that my services in India would probably better served than working with somebody in UK where I'm actually assisting a lot of people, not doing myself anything. So came back and started practicing in 2006 in a private hospital where I think I was the first orthopedic surgeon in that hospital, which is predominantly a mother and child hospital to begin with, and made it into a multi-specialty hospital. I think this journey of medicine and all that started when I was in 7th. I had a small tragedy at home when one unqualified person treated my maternal aunt. She passed away with some injections. That was a time when I think there was a strong feeling that something can be done if you are a proper doctor. Very young, no real intent to be a doctor at that time, but since that day I wanted to be a doctor.
Anyone in the family, who is a doctor?
My dad is a vet, but not a medical doctor. I'm the first one.
So why orthopedics? That would be the most obvious question. Somewhere along the way when you were doing your MBBS final year, or somewhere you would have decided that this is where I want to get. Was that a well thought of decision?
Yes, I mean surprisingly happened in the first year itself. The first year we had anatomy, the dissection hall, all cadavers. A lot of people got really scared to go into that hall, but I took it to the cadaveric dissection from the day one, and I was very, very comfortable and felt very happy to actually explore the body surgically. And that's the day when I said I want to be a surgeon. I don't want to be a doctor who just prescribes medicine, but I want to be a skillful surgeon. And my first love was neurosurgery in the very beginning of the days, because I always felt like the core is brain, then the spine, and then the skeleton. Everything else I felt was secondary. The entire MBBS journey, I was very vocal about my love towards spine and my orthopedics.
So 27 years in this field now, and obviously if you look back in moment in time or experience, what pushed you into becoming an orthopedic? We know that right now, but then the point is, how did you decide that you would again specialize in that? You said you went to UK, and many stories I heard similar. People want to come back and serve them other. But orthopedics is demanding field, emotionally and physically at that. What are the early challenges that shaped your philosophy in this as a doctor and as a leading people?
This also has one background. Probably in my 10th in school, we went for a picnic. Had a bad tragedy. Lost two friends on a road traffic accident, and they both were carried to a hospital in Karinagar. We waited for almost 8-9 hours to know what is happening, and they told they were operated, but both of them lost their lives. That was there in my back of my mind. I still remember my two classmates' names and everything. One Balakrishna and Jyoti. When I was thinking about it, when I saw actually the accident happening, then I said, I think a very skillful surgeon. This is all, without any data, without any real this thing, but I was thinking a very skillful doctor and a good infrastructure would have saved them. Was my impression. A good doctor, good hospital would have actually saved my friends. I feel that was there in the back of my mind all the time. And when I actually went into medicine and when I felt very comfortable operating, dissecting the cadavers for my anatomy, I always wanted to be a surgeon. And trauma was one of the very close to my heart. I wanted to save people who had accidents, and that's the reason why I think I was focusing on neuro and ortho, which both of them were very, very related to trauma. That's where it started. Then when I went to Manipal, then I realized orthopedics is not just trauma. We had all subspecialty training, huge understanding of the orthopedics, and I loved every bit of orthopedics, all kinds of orthopedics.
Obviously, as I said, you must be treating some complex cases in your entire career. What does healing personally mean to you today versus when you first started?
Yeah, when I started, the understanding always was to have that clinically, as a doctor, it should be fine. But the patient perspective was not too much in my early days. I always felt, okay, my patient is comfortable, that's done. But as I grew as an orthopedic surgeon, as a doctor, I realized that treatment is not just what you technically give. The treatment actually involves the family, the patient himself, his functionality, his social, financial, emotional status. All of them are actually make it as a single patient. And it's not just one person, it's a family. And even that person's all other things. As I said, his social background, his occupation, his financial status, his psychological status, all of them actually are important in getting the best result out of whatever I treat. That's a big change over a period of years as I understand patients more.
Joint replacements, trauma, you spoke about spine, bone tumors. The spectrum is pretty wide. Which area gives you the deepest sense of fulfillment and why? Of course, that would be tough to ask because it's like asking a parent which of the three children are their favorites. But still, I would ask you that among those four, what would you like to do the most?
Yeah, obviously. I love all of them. I still practice all of them, but now I'm more into joint replacements as a specialty. But any day, I think it's trauma. Either it's a domestic trauma, a senior citizens having injuries, and the very important point which I wanted to actually make is in my practice. If you look at me. 60 to 70% of my patients are more than 60 years old.
Okay.
And most of them will come with degenerative changes or injuries at home. Falls and mobility, I think, is the most important thing for independence. That's what is my core focus right now. There is one point, it's a little cliche, but bed to bathroom distance is the most important distance for independence for an old age person.
Okay.
Everything else can be probably assisted by people, but if you can't go into the washroom on your own, I think the life becomes a hell for the patient himself and the family also, whatever is the situation. So the older people I see are more aggressive, that's what people call, to make them mobile. So I operated on a 104-year-old lady with a hip injury. Everybody said she's 104. Why are you operating?
Okay.
It probably it's risky. I mean, whether she'll tolerate it or not. Then I told the family, I'll operate. If it is fully successful, she'll walk from tomorrow. If God forbid, if something happens, I think she has lived her life. But don't give a painful life of whatever few months or years she's going to live. And that's been my concept so far. The quality of life becomes more important than the number of days they live as you grow old. That's how. And she walked for a year after the surgery, and she passed away due to aging. This thing, and that family still reaches back to me on and off.
In fact, that was actually my next question, but you took it away. But still, I'll ask you that in trauma care, every minute counts. But of course, this is not technically a trauma care, but still. Now, can you share a real case? Of course, you need not take the name of the person because you saw that accident happen with your friends when you were not a doctor.
Yeah.
But after becoming a doctor, did you see a case like that fundamentally changed the way you approach emergencies?
Yes, I did. I mean, we keep seeing them even today. The patient was had an accident. Multiple people were in the same accident. This is around 2-3 years into my practice. 4 people came in. One of them were ruled out that he cannot survive. Had fractures on one part of the entire body. His leg, his thigh, his forearm, his shoulder, his arm, everything is fractured. His pressures were very, very low. The patient is still alive, walking around, very happy. He always calls up, his children call up and talk to me. That's the difference what I made to one life, and that actually changed because the way we approached that patient was incredible. We took the patient to surgical listing in, I think, around 40 minutes. And blood was arranged, everything was done. And we gave them less than 1% chance of actually survival. But we did everything possible. And that's when I said, trauma, there's always a chance to survive if you aggressively handle that patient. And we still do those things. And I think the trauma centers on the national highways, which is a big plan. When I was in ISB, a management graduate, we had a big plan of creating a network of trauma hospitals and all that. But my strength, either financially or human resources wise or planning wise, was clearly not enough. And that's the probably year when actually central government came out with a plan to have trauma centers every 50 kilometers on a national highway. That needs to be done. If you want to really save people, I think the trauma centers on the national highways is something which you should do and implement it. That will save a lot of people and that will actually save a lot of families.
Time the golden hour that is there, of course, Nitin Gadkari needs to work on that.
Yeah.
But coming to the other part of it, which is a joint replacement, success today is effortless, but patients don't see it as the precision behind it, what happens behind it. They don't really understand. Of course, they don't need to also. But why do you believe this hidden science that patients should understand about what actually goes behind the joint replacement part?
See, versus trauma, if you look at the joint replacement, we are looking at a patient who is otherwise healthy, who just have pain in one of the joints with probably the mobility is becoming difficult. So all of them are in elective cases. This is not like an emergency. So a lot of patients will have a lot of time to discuss with people, go through whatever information they have. They do a lot of research in their perspective and then come to the joint replacement surgery. What they don't understand is it's not a disease, it's an aging process. So you are not looking for a cure. You are actually looking for replacing something which is already degenerated. And every single patient is unique. And their pain tolerance levels, their muscle strength, their bone strength, everything is different. So they always try to compare with their neighbors, their family members who had the surgery, and then think they get worried that their surgery was not successful. These guys' surgery was not successful, and everybody defines the surgery success differently. So what I do is to make them fully aware of what is this condition, what is expected out of them, and what is their role. surgical intervention is only part of the story in joint replacement. The effort from the patient and a little bit of effort from the family post-operatively is very critical. And surgical technique or the surgical skill is also very, very big part in the outcomes, which I think now slowly is fading away because of the technology coming in. The training is happening very well. A lot of people do good work. Still, there are exceptional surgeons versus good surgeons versus bad surgeons.
In fact, that's the joint replacement often is seen in case of elderly patients. There must be, of course, exceptions. But spine surgeries, coming to that, because that often intimidate patients. When you talk to spine, there's always the spill, the chill that goes up the spine, as they say, they're scared of it. But how do you simplify the entire thing? How do you counsel somebody who just diagnosed with a spine condition, saying, you need surgery and this is how we'll go about doing it? How do you calm down the patient?
I think most of the patients who have spine surgeries are in two different cohorts. Very young patients with significant physical activity, which is inappropriate physical activity. And second one is again a degenerative kind of spine where elderly patients having issues. So in patients with significant pressure on the back and having some disc issues and all that, it's a very, very simple surgery. I mean, if you have one disc issue, then you can just attend to it. Now we have endoscopic surgeries, minimally invasive surgeries. You are up and about same day. So people doesn't have internal not enough for them to understand what is going to happen. Once they are very clear about their condition, what is going to happen and what is the outcome, I think 99% of the patients are comfortable with the spine surgery also now. Lot of parts which are in the circulation, that is what we address actually. We tell them, see, lying down on the floor may not be the solution for backaches. Getting some massages which are not technically right may not be the solution. And some surgeries are very, very simple. They don't have to really worry about even the complication, because the complication rate is so significantly small. So these are the things I think once they understand, most of the people are comfortable with it.
Now that we're done with the medical part of it, which is basically the hospital, joint replacement, the spine issue, trauma care, we'll come to your part as a CEO, CO, and Chief Orthopedic Surgeon. The mind shift required to move from that part of it for a doctor to become a healthcare leader. And I've seen this in many, many people actually. Some of them openly admit that they couldn't make it. They are good surgeons, bad leadership roles. Running a hospital is a different cup of tea. What do you think, sir?
Yeah, I think leadership does require a different mindset. And most of the leadership roles actually doesn't come on their own. I mean, you need to show them that you are a leader from the early age of your life. I think the mindset of leader should be a person who actually thinks about others more than himself. That's the first thing. And a person who is got the integrity as his core. And a person who can think of little bit of future, not just the present. I think these three things needs to be there for a leader. And if you are looking at yourself, then you can't be a leader. If you can't think of little ahead of time at least, you can't be a leader. And if you can't manage the teams, then you can't be a leader. So from the beginning, I mean, from the school days, I was heading the class. Then I was in medical school. I was part of the managing whatever we have association and all that. But they were all like, they're not training grounds for your leadership, but your mindset to take everybody with you. Looking at a much broader picture than a very, very tubular. What is there for me? What can I do for myself is something which kills the leadership. And if you can't think of giving more to others than yourself, then you can never be a leader. That is my understanding so far. I don't know if it is right or not, but so far I think it's working right.
I mean, there's a difference between running a hospital and performing surgeries. Sometimes you have to do both the roles.
Yeah.
And sometimes you have to put accent on one and then reduce the dependence on another. how do you what kind of systems or habits have you acquired over the years to balance these two?
I think there's a lot of hard work. I spend around 18 hours, 19 hours a day effectively to balance all my activity, and I'm comfortable with that so far. I'm not actually advising somebody to do it. That is my comfort zone. Everybody has got their own comfort zone. I'm also a little bit of tech dependent. I get a lot of my data worked up, and I spend a lot of time on my data to have my decisions made. And I spend a lot of time interacting with people whom I actually work with. And I believe in delegating. I actually do develop a team which takes care of everything. For everything, I have a team. And that's what is my strength so far. I have teams for everything, and the team is my strength.
Young doctors, they have a problem. In fact, how do you kind of teach leadership lessons to them at a pretty young age so that they could develop that and polish it up as they grow up in life? What is the one leadership lesson? If you want to say more than one, you're welcome, but if you can at least enumerate one leadership lesson that a young doctor could acquire.
The core is the integrity. Okay, if your integrity is questioned, then you cannot be a leader. That's the very core of leadership. Then, if you are just looking at the healthcare, I mean, we'll focus it on the healthcare first. If we are looking at the healthcare with values should be the leader's perspective. If you are actually looking at healthcare as a business, healthcare as money-making machine, then you can never be a leader. Any leader who is actually established big, they always looked at patient care and healthcare with a lot of values. Your ethical, moral grounds needs to be very clear. Your focus should always be a patient care only. And all my communication with my teams, I always put patient as my central point. And if you are looking at the healthcare, patient-doctor relationship is the core. Everything else is secondary. And that is what I actually teach everybody. If you are looking at my talks, if I have to communicate with people and all that, I always tell them the patient-doctor relationship is the core in healthcare. And everything else is built around it. If you are putting a lot of infrastructure, that's just a medium to deliver your healthcare. If you have administrative people, they are just facilitators for this execution of healthcare. They are not the bosses. Some places, I think what's the problem right now is the administrator or the management guy thinks he is running the hospital.
Okay.
That's where I think there are a lot of issues, but the core is patient-doctor relationship, and that's what I think I've been practicing, and I'll advise people to understand it.
In fact, in a country like India rather, where a doctor is looked upon as a god sometimes, and I think that makes a lot of sense. Now, you did mention that you are a tech person and you use a lot of technology part of it. Now, coming to innovation, AI, and of course the future of orthopedics, that is where the entire accent is today, like in any other specialty within healthcare. You're also an angel investor and an AI enthusiast. What excites you most about AI in orthopedics and trauma care? Because we've seen that a lot of accent is being placed by different disciplines. Forget the healthcare part of it. In AI, I think that's where the future is. So that's my question.
Yeah, I think personally I believe the real AI is not there yet, but we are actually progressing towards it. My direct relationship with whatever technology I'm talking about, see this robotic surgery in joint replacement, where it's a mix of machine and man. Robot doesn't actually operate on its own. We operate that machine to get the precision which was not possible by only human. And there a lot of algorithms help in planning and executing that precision. So robotic surgery, now I'm a robotic joint replacement surgeon. The change between conventional surgery and a robotic surgery is very minimal. But for a joint which needs to survive for 25-30 years, even that very minimal difference is going to make huge impact on the patient's life. The second part, I always believe in data. there's a lot of hunch in a lot of people, but in medicine also they say, in my practice I do this and it works. That's, I think, pure hunch. Okay, with lot of practice you still do your data analysis without putting numbers on the paper. But if you are really trained in those basic data analytics, I'm sure the healthcare is going to have a significant difference. The good quality of data is still not there yet. We are going there now. If you have real good data, because healthcare for each location, for each person, for each country is different, and that precision can come only if you really work on your local data, not on the global data. You need to have your local data, and based on your local cohorts, your local information on the health, that's where I think the difference will happen.
In fact, do you think meaningfully, if you can talk about supporting surgical planning and decision making on AI, that is using AI for the next, we'll not go beyond 5 years, say 5 years from now, how will you use AI in managing surgical planning support or decision making?
Definitely, I mean, the AI is part of this robotic systems. Basically, we are now able to work with some robotic systems where the alignment of the joint is decided before we actually put the implant in. You can assess it fully, then you can decide exactly what is required for that particular patient. Now it's become so precise that your right knee and left knee are different. The amount of degeneration, the deformity, the muscle strength, everything is not exactly same in one person, both knees. So that kind of precision can come with your robotic help.
It's like, if you could, when you talk about investing as a startup investor and all that, but if you could invest in one healthcare innovation that could transform the orthopedics in India, what would that be?
Very difficult question to answer. Something which can give very good data collection and analytics, I think I would love to do that, because that's where we are going to have real insights into in both ways, the sickness as well as the wellness.
Those youngsters who are looking to, start up the idea, here is one for you, and then I'm sure that you can come back and talk to him whenever you find time to get more ideas on that. But we'll go on to the next question, Doctor. How should young surgeons, for example, prepare for future, where technology and human skill must both coexist? You did speak about the surgery where you use robotics, and you say it's hard to reach areas. Robots can do that thing. There's pinhole surgery today. A lot of stuff which started early, but now we're coming down to micro stuff. So how should young surgeons today prepare for this? Where future is healthcare on one side, human skill, technology.
Whatever technology comes, ultimately it's a human skill which is going to make the difference. So any young surgeon who really wants to do good should train themselves well, and they should continuously learn. The learning is lifelong. It can't be like, I've done my training for 3 years, 5 years, I'm an expert in it. I mean, that is not going to work anymore. You need to continuously learn. In fact, I'm doing that before I actually preach.
Okay.
I am going for next level of robotic training in the next month to one of the best institute in the world in Singapore. So my point is, unless you understand that your learning journey needs to be continuous till you practice, you cannot grow. The second thing is, validation is one word I tell every one of my startup, every one of my people who actually talk about healthcare. If you are talking about any new idea, the validation has to happen. Any new surgical technique, validation has to happen. But this validation has to happen for the surgeons also, for the doctors also, for the technical people also. Unfortunately, I mean, probably some people may not like to hear this, but with so much of social media around, when you can talk about yourself a lot and reach people whose understanding of the things is not too deep, without having a validation, a lot of people claim that they are experts in it. And that is where I think the misinformation is leading to a lot of healthcare issues nowadays. So I think if you want to really do well, your validation needs to be perfect, your learning needs to be lifelong, and you should always have an appetite to build a team around you which will have complementary skills. Every doctor cannot do everything. A doctor cannot do everything of even one subject. If you look at orthopedics, there are at least 5-6 subspecialties, and if that is the case, then you need to have people who can do different things to complement each other. So any young surgeon, if you want to be alone, then it's going to be trouble.
Coming to mentorship, startups and entrepreneurial lens, actually, you mentor startups at T-Hub and SeedSpark. What common gap actually do you observe in healthcare founders? There will be over a period of time who would have dealt with these people. In that, the way they approach a clinical problem. What are the things that you observe?
I'll give you a couple of scenarios. Basically, a lot of non-medical persons who are working on healthcare things, they usually start with one of their experiences. Either when they went to a hospital, they had some issue, and without actually checking whether that problem is a one-off problem, which is not really an insignificant problem, they'll think that's a huge problem. The problem statement itself is actually wrong. That's where they usually start, and they think that problem can be solved with some technology, some innovation and all that. They spend a lot of time before reaching out to somebody who can tell them that that's not a problem at all. It's a one-off incident. Okay, that's one big thing. The second thing, again, if it's a non-medical person going for a healthcare startup, as I told, validation is going to be very, very difficult. So having one medical team member in the very beginning of their journey is very important. May not be as a founder, co-founder and all that, at least as an advisor. They should be able to understand that problem statement and the solution, whether it's actually useful, whether it's actually relevant. By the time a healthcare innovator comes out with a solution, they're already late by 3-4 years. Most of the time, that's what happens nowadays.
They're outdated by that.
Outdated by that. And the third thing is getting access to validate their solution is a big challenge. Because
you need data for that.
Correct. We need data, and you also need some real-time scenarios where if somebody comes with an idea which I have to use it on my patients, I'll be very hesitant because it's a real patient sitting there. I'm a real doctor. I'm trying to use something which I'm not still sure or it's not confirmed. Then it's a difficult part. So whenever you are thinking about a solution, you should also think through whether this can be implemented without harming the patient, whether you can just check this on the real scenario or not.
In fact, it took away again the next question, which is basically saying what are the solutions, what advice would you give it to first-time founders for building solutions for hospitals and surgeons? I think you took that away and you answered that. Anyway, we're coming to the biggest gaps in India's trauma care system, in orthopedic care especially. And what can actually solve in the next decade? What kind of gaps? How do we solve this gap that is there in India's trauma care system? You did speak about the way national highways are a big issue, where still the solution is not there, and if that is done, the golden hour is taken care of. And when you talk about how can you practically solve this problem? Is it just by setting up trauma care, or is there something beyond it where the patients can be helped out?
Yeah, I think I can't really tell you the full numbers, but if I look at my practice 10-15 years ago versus now, the mid-level of trauma where you have fractures, then operated on it and all that has significantly came down. I think there are various reasons. The road infrastructure is better, the quality of vehicles are good, the people's understanding of these accidents and their consequences are definitely better. I think drunk and drives which made people
scared.
Avoid, probably scared after under the influence driving and all that. I think these are some things which worked a bit, and these high-speed accidents where they're not coming to hospital. I think that's where the focus should be. The first focus should be. So people should understand if their vehicle, the road, their skill, all the three are matching for the kind of speed they go. Whether this road on which they are going, whether it's actually fenced road. There's no fenced road in India, right? You can suddenly expect anything out of the blue onto the road. You suddenly try to stop or turn and then you're gone with a kind of this thing.
That's true.
I think that's a big thing. Basically, the infrastructure level, the quality of vehicles you get out on the roads, education to people. These are all, it's at a much broader level. When it comes to post-injury, I think every single school should teach the children of say 8th, 9th to 12th, between 8th to 12th class. They should understand what is trauma, what should be done to prevent it and to attend when there is a trauma. See, there is a lot of activity happened with regards to CPR. When you have a person having an issue, then at least a lot of people understand the word CPR. The same thing should happen with the trauma too. If you have an accident, if you have an injury, then what are the first 2, 3, 4 things you should do? And that awareness can come from the schooling itself. At the age of probably 10, 12, 13 years to 17 years. Because those are the ones, the next 5 to 10 years are the most critical people on the road.
In fact, one of the things that as we speak about accidents is also the fact when you speak of spine and other issues, we did briefly speak about that earlier. Today, the number of people working in sectors like IT and many other sectors where they're kind of fixed to a chair for the entire better part of the day, and maybe even when they go home, they start the same thing all over. Many people work from home all through the week. Most of them have this issue about back problems, they have tennis elbows issues, they have problems with their fingers, they have various issues about using mouse and other things. What would your advice be to this young audience who have this problem, who come to you at a very young age saying that I have these issues? What do you tell them? That these are 10 things you need to do, or these are the 5 things you need to do?
I think first thing I would suggest to all the people who work on the desk with the systems, they need to reverse one important thing. See, the habit is to have a desk which is ready. Your table is there, the setup of your system is there, your chair is there, everything is there, and then you are trying to fit into that system. Ideally, you should sit comfortably, you should have that proper position and everything. Then you set up everything according to your seating, which doesn't happen. You always actually adjust yourself into your working place. And it happens at home also. You are sitting on the bed, you are lying down on the bed and working. We are in all different kinds of shapes and
mobile phone usage.
Exactly. So there's one important concept here is a repetitive strain. So whenever you are doing the same activity repeatedly, then you're injuring your tissues, which doesn't happen in one day. It happens over a period of few months, years, decades. And once that repetitive strain reaches a stage where it can't repair itself, that's when you start showing the symptoms. So the day when you had a symptom is not the starting day. It probably started a few months, years back. So the best thing is to have prevention. What I tell every one of my patients is, first you sit comfortably. Whenever you sit at the back of the chair, no gaps in between. Your shoulders needs to be close to the body, your neck needs to be straight, and adjust everything into this zone of work. That's first thing. And I think a lot of people would have heard it, the sitting is next smoking or whatever. So every 20 minutes you should take a break of 2 minutes. That's what I advise everybody. Walk around at least 2-3 minutes every 20-30 minutes. 20 minutes is what I tell everybody. Even at home, even for domestic work, even for homemakers, I think they want to finish off everything the first 2 hours and then take a break for an hour. That's absolutely not going to work. Every 15-20 minutes they should take a break of 2-3 minutes, and that can give them the whole day to work. And it is for the IT, it's for everybody else. Even when I practice, even if I'm seeing patients, I always get up, go to the patient, examine, then sit. These things I think every doctor who is seeing the patients do practice. But the profession has given us a chance to do it. Some people doesn't have a chance to do it naturally, then they have to do it as a practice.
Another sector which, as we coming to the close of the conversation, another section of people who have a huge amount of problems in orthopedics are the elderly. As they say, after a certain age, the bones don't set. There's a degeneration that is happening. Among women, there is osteoporosis and other things. But I know it's difficult, as you said, from the bed to the bathroom is a major issue. What would your advice be to elderly patients? Of course, you can always say, make sure that the bathroom doesn't have water splash around it, or when you walk, watch your step, all that. But what is your advice to elderly patients?
See, there are two important things which all elderly people would face. One is osteoporosis. The second thing is sarcopenia. Sarcopenia is loss of strength in the muscle. These two are very critical. You need to have a good quality of bone and you need to have a good quality of muscle. If your muscle strength is good, if your bone quality is good, even if you slip, fall, your injuries are very, very low. And the balance comes with your muscle strength. So anybody who wants to be independent should have some kind of an exercise to maintain their muscle bulk as well as the strength. And osteoporosis, of course, it's predominantly seen in the understanding so far, but every male also will have osteoporosis beyond 65, 70. The rate at which they lose the bone may be slightly different, but in particular Asian population, the male osteoporosis is almost as good as female osteoporosis, which starts a little later. And every woman who passes the menopausal age will suddenly start having the changes in their calcium metabolism, we call it the hormonal thing. They should start addressing it at least 3 to 5 years ahead of their menopausal age. So having just calcium will not work. You need to have three things. I mean, very, very basic stuff is you need to have enough vitamin D, you need to have enough calcium, and you also need to have enough impact exercises for the calcium to get and deposited onto the bone. So if you are lying down on the bed and taking loads of calcium and vitamin D, it's not going to work. If you are taking a lot of calcium running around but no vitamin D, it's not going to work. So all the three are very, very critical for maintaining the bone health. And for you to have that balance, for you to be independent, even if you have a strong bone, if your muscle is not good enough, then it's not going to work. Maintain your muscle strength, maintain your muscle bulk, maintain your quality of bone. Then the chances of you to be independent are very high.
Another place where we see a lot of accidents happen, technically accidents happening, are gyms. A lot of people go lift weights, do fast walking on treadmills, and do various kind of sit-ups and all that. Of course, it's good to be fit, it's good to be agile, but then a lot of problems start there. What would your advice be to these people who frequent gyms? What should they do and what should they should not do?
Yeah. I mean, on a lighter note, I want to tell you something. This I noticed a few years ago. When Yoga Day was introduced and practiced, which is an exceptional concept, but the entire nation wants to focus on their health, and but then we have noticed a significant spike of patients into the hospital post Yoga Day, because suddenly they realize yoga is very good to them and they start doing it without having any idea about what is suitable for them. The yoga per se is a science. That's what I believe. And it requires a proper guru for you to start doing the yoga. For every patient, there is a different kind of system. So every person needs to have a proper guru who understands their body, and that's when you should decide what kind of yoga is suitable for them. You can't just watch on the TV and then start doing it. The similar thing with the gym. You suddenly want to start becoming very healthy, and you push it so hard in the first few days and your body fails. And that's where the injuries happen. This whole of gym journey should be like a lifetime journey. It can't be like in 3 months I'll lose some XY number of kgs and I'll build my biceps and I'll have this big chest and all that will fail for sure. So your gym, your health is a lifelong journey. It can't be for a very short period of time. That's, I think, something everybody should understand. And always start slow. Always start which your body can take. And even if you're not comfortable with the very little exercise, it's good if you can continue. The persistence of exercise is more important than amount of exercise what you do.
In fact, New Year is coming up, so a lot of people will take resolutions to hit the gym from 1st of January. But one of the last questions I have for you is, of course, the fact that in cities like Hyderabad, Bengaluru, Delhi, or any other modern metros, or even the big cities, there are proper orthopedic facilities. But like any other healthcare specialty, when you go to the tier 2 and tier 3 cities, that is where the problem starts. They always need to travel to the city to get something fixed. Of course, there are local hakims and all that, people who do all this kind of stuff, but then that is like having your RMPs do healthcare for allopathic medicines. But the question is obviously, if you could redesign the healthcare pathway in Indian tier 2 and tier 3 cities, what would you change first?
Yeah, I mean, it's an established model. Hub and spoke model is an established model for most of the healthcare systems, which are there in supposed to be developed countries and all that. You can't create a big trauma center, a big hospital in every village,
True.
right? And luckily, for most of the orthopedic things, it's not like a life-threatening emergency every time, right? Yeah. So you still have time. And if your access to that care is not too far away, then it can work. So we should always have a small spokes in villages, mandal headquarter level, and have one hub which can take care of at least say 100 villages, 200 villages, 500 villages with very good interconnectivity. Your ambulance systems, your road, somebody who is has got basic trauma life support training in each village, who can assess that very quickly and does that primary thing and then take the patient to the next level, can work for the trauma. And they need not actually travel to major cities for 90% of the trauma things, unless there is a head injury, weak spine injury, polytrauma where multiple things are happening. Those are the things which requires much bigger setup, a huge skill set. A lot of other things like blood bank needs to be there. You need to have a team of trauma specialists, your neurosurgeon, your orthopedic surgeon, probably an abdominal surgeon, a chest physician. Everybody needs to be there, but the number is very less. So for trauma care to happen, I think a hub and spoke model where a big hub taking care of a lot of spokes and the interconnectivity between them should actually take care of it.
In fact, it's wonderful speaking to you, Dr Radhakrishna, because it's such a big subject. We could compress it into say 50 odd minutes, but I'm sure the next time when we meet, we have a larger canvas to operate in. But you did speak about the intersection between science, strategy, and compassion in a big way, and how, as an orthopedic surgeon and a visionary healthcare CEO, you're redefining how experiences that India has by merging clinical brilliance with future-ready innovation. Thank you for speaking to us. Thank you, sir.
Thank you. Thank you so much.
Thank you. Ladies and gentlemen, that is Dr. Radhakrishna, a person who believes that AI intersects with healthcare in many places, and especially orthopedics. He has advice which is given you in terms of how to stay healthy, what to do and what not to do. He speaks about his research, he speaks about his concept of AI that he believes works, and of course, how healthcare intersects with technology. And that is extremely important. Thank you for watching. Jai Hind.